Hello everyone, welcome to our channel Forensic Pulse Crime to Code. Today we'll see about kidney forensic histopathology. So this single video is useful for all the 3 years, that is the first year for anatomy and histology part, and second year for pathology part, and third year for forensic histopathology. So let's move on to the session. So these are the contents in which we'll be seeing the session today. So first let's brush up the basics. So this is nothing but a normal H&E stain. Here we can see clearly the renal corpuscle. So this renal corpuscle is having the Bowman's capsule. So I'll show the Bowman's capsule now. So this part is the Bowman's capsule. It is lined by the squamous epithelium. And then we have the tubules. These are the distal tubule and this one is a proximal tubule. In future slides, we'll know how to differentiate the PCT from the DCT. So these tubules are lined by simple cuboidal epithelium. So this is the periodic acid Schiff stain. So this depicts the renal corpuscle, each of which consists of an outer envelope, the Bowman's capsule, surrounding a fluid-filled space, the Bowman's space, within which is suspended the glomerulus. So in this image, the Bowman space may be seen as an opening into the beginning of the proximal tubule. Okay. So then we have the vascular pole of the renal corpuscle here. So this periodic acid Schiff stain accentuates the filtration membrane as well as the basement membrane of the renal tubules and the Bowman's capsule. So this mesangial matrix is also pass positive. So although the glomerulus in this image clearly contains many cells with varied appearances, the individual identities like endothelial cells, the podocytes, the mesangial cells are difficult to determine in relatively thick sections. So we need to do thin sections to see individual cells of the glomerulus, and we can also try doing other special stains. So now let's see how do we spot the difference between the PCT and the DCT. So this guys, so let's see which is PCT and which is DCT. So just think about what is this cell and what is this cell. Just think for a minute. I'll be telling the answers now. So here as we see, the one which has a bright lumen, where the lumen is clearly seen, is the distal tubule. So this is the distal tubule. This is the distal tubule. The one in which we are not able to clearly see the lumen is the proximal tubule. So how am I saying this? This is because the proximal tubule is lined by simple cuboidal epithelium whose cells have several characteristic features, like the apical end of each proximal tubule cell has a brush border of microvilli. So this apical cell of each proximal tubule cell has a brush border of microvilli. So this provides increased surface area to accommodate the membrane channels that are responsible for absorbing the small molecules from the filtrate into the tubular lumen. So the brush border is seldom plainly visible in routine histopathological preparation, but proximal tubule cells tend to have indistinct apical ends in contrast to the distinct apical ends in the DCT. And then another distinguishing feature of proximal tubule from the distal tubule is that the proximal tubule is intensely eosinophilic, as you can see here. It is more pinkish than the distal tubule. So let's wonder why it is so. This is because the proximal tubule cells have a higher proportion of mitochondria in their cytoplasm that provide energy for pumping ions and molecules against the concentration gradient. So for these two reasons, we can easily differentiate between the PCT and the DCT. The first reason being the apical brush border of microvilli that is present in the PCT, and the second reason being the increased number of mitochondria, making it more eosinophilic, more acidophilic in PCT and less acidophilic in DCT. So let's revise them. Both are made up of simple cuboidal epithelium, but PCT has indistinct apical ends. Intensely acidophilic BCT, this also has simple cuboidal epithelium and it has definite apical border of cells and it is less acidophilic. So this is just an overview. So as we know, these above this is the renal cortex and below this is the renal medulla. So here we can clearly distinguish this is a PCT, DCT. Similarly in the medulla also we can easily differentiate. So let's see some of the cases that we got in our institute. So this is a case 1. So this is a case of benign cyst. We can see adjacent foci showing cyst in the wall lined by flattened cuboidal epithelium. The kidney shows benign cyst. So this is a classification for cystic lesions of the kidney. What is important for forensic perspective is simple renal cyst is a very common finding. Okay, this part simple renal cyst is a very common postmortem finding. They are usually seen in people above 50 years of age and it is seen in hypertensive patients and mostly it is asymptomatic. Symptoms occur when the cyst ruptures or if there is any hemorrhage or infection. So yes, as I told, in hypertensive it is more common. So let's see the case 2. It is a case of ATN with autolytic changes. So this is a slide. So the sections from the kidney show acute tubular necrosis. See, here I have focused the tubule. See, uniformly you can see the tubules are lacking. The nuclei, the basophilic nuclei is absent here. So this is a feature of acute tubular necrosis. So this is ATN, acute tubular necrosis. Then we have focal interstitial chronic inflammatory infiltrate composed of lymphocytes here. These are the lymphocytes. Then we have congestion and focal areas of autolysis are also seen. So these are the congestion part. So we have the same section. Here we can see easily the congestion and autolysis part and this see here this is the tubule and here we can hardly see any nuclei. So this is a feature of acute tubular necrosis. So acute tubular necrosis is nothing but acute renal failure resulting from destruction of tubular epithelial cells. So it is a important classification or a thing to remember in pathological perspective. So we have pre-renal, renal and post-renal causes. Pre-renal is due to some obstruction or a problem in the perfusion of the kidneys. So this causes sudden decrease in blood flow to the nephron. Intrarenal or simply renal causes is due to the vascular disease of the artery and the arterioles within the kidney, disease of the glomeruli, acute tubular necrosis due to ischemia or nephrotoxins, acute tubulointerstitial nephritis or pyelonephritis. So in pre-renal, we have other causes like cardiac output and hypolimia and vascular disease. But here we have vascular disease of the arteries and arterioles within the kidney. Okay. So now post-renal causes are mainly due to obstruction. So this is the next case. This shows cortical necrosis with congestion and necrosis of the glomeruli in the proximal tubules. Peritubular capillaries are markedly dilated and congested. So this is a feature of acute kidney injury with cortical necrosis. So this shows the peritubular capillaries that are dilated and congested. Next is case 4. So this is a slide. Here we can see tubule showing tubular injury and ischemic injury and glomeruli is showing ischemic necrosis, acute tubular injury. So this here we can see there is thickening. So let's see what is this like. Renal parenchyma with few glomeruli showing global sclerosis. The glomeruli is sclerosed here. And tubule showing protein resorption droplets. Blood vessels show medial wall thickening, suggestive of hypertrophic atherosclerosis with luminal narrowing. So these are the changes secondary to hypertension. So this is the medial thickening. So this is general feature of hypertension. There is subintimal hyperplasia and hypertrophy of the vascular media. In addition to the small vessels with eosinophilic amorphous material deposition in the media manifesting as fibrinoid necrosis. See, what is fibrinoid necrosis? There will be a damage to the vasculature due to which the substances inside the vasculature will leak out into the interstitium causing the inflammatory infiltrate as in here. So fibrinoid necrosis is a microscopic tissue injury to small blood vessels where cellular components leak and accumulate causing glassy pink staining appearance on the sides. So it is a result of autoimmune conditions like SLE, erythematosus or sometimes hypertension. So next we have the K6. So this kidney shows mesangial matrix with expansion of few glomeruli with showing nodular sclerosis. These are the Kimmelstein-Wilson lesions. I have the enhanced view of the Kimmelstein-Wilson lesion in the next image. Here we can see the inside the glomerulus. We can see a eosinophilic mesangial cell that is clearly seen. Okay, so this is a feature of diabetic nephropathy. Many tubules show acute tubular necrosis. So medial wall hypertrophy and hyalinosis is also seen here. So this is a feature of diabetic nephropathy with acute tubular necrosis. So this is a Kimmelstein-Wilson lesion. So this is a Kimmelstein-Wilson lesion. This is the nodular sclerosis of the glomeruli. Okay. So other forensically relevant findings. So, kidney samples are not routinely sent during autopsies in absence of any gross findings. The commonest pathological findings in the kidney are ATN, as we discussed, chronic pyelonephritis, glomerulosclerosis, interstitial nephritis, renal cyst, as in hypertensives, and nephrolithiasis. Even though these conditions of the kidney are not directly responsible for the death of the individuals, they could have contributed to these deaths up to some extent. So this is a slide of chronic pyelonephritis. So here we can see the tubules resemble like uh, thyroid colloid molecules. So because of which this is called as thyroidization of tubules with dense chronic inflammatory infiltrate in the interstitium. Ethylene glycol poisoning, it is seen in antifreeze poisoning cases. We can see bright calcium oxalate crystals, this one within the kidney in case of ethylene glycol poisoning, and the high power view of calcium oxalate crystals show like fan shaped appearance. So this is the routine H&E stain and this shows the birefringence. So this is a case of excited delirium with hyperthermia. Here we can see the myoglobin that is present due to skeletal muscle breakdown in excited delirium in hyperthermia cases. So this is a slide of autolysis of the kidney. There is diffuse pallor of the renal parenchyma with loss of nuclei. The epithelium of the tubules has separated from the basement membrane. So we can see the basement membrane, the epithelium of the tubules has been separated. So this is an important finding to be noted to differentiate between autolysis and ATN. There is a preservation of the collecting ducts here. So this is the autolysis. There is loss of epithelium. Some of the collecting ducts still display some shape to the epithelium but have separated from the basement membrane. The glomerulosclerosis and the increased interstitial fibrosis is noted here. So this is ATN. So I have told in the previous slides how to differentiate between the autolysis and the ATN. See, there is vacuolization of the cytoplasm and the epithelium has a grainy quality. So as the tubular epithelium separates from the basement membrane, tubular hexis is seen as you can see here. It forms coils. It is not seen in a autolysis case, but in acute tubular necrosis case, we can see the coils. So ATN caused by ischemia the PCT are more susceptible to ischemia than the distal tubules. Here, there is vacuolization of the cytoplasm and the epithelium has a greeny quality, and the nuclei are still evident but are pycnotic as they begin the process of apoptosis. As the tubular epithelium separates from the basement membrane, tubular hexes, it forms coils and a finding are not seen in autolysis. These changes are focal, occurring in different regions of the kidney, and like these are focal. Okay, in different regions of the kidney, we can see these focal changes. Unlike the autolysis case where it is a diffuse process, we can see it is a diffuse process. It was a diffuse process in autolysis, whereas in ATN we can find the focal regions. So, another use of kidney forensic histopathology is estimating the time of death in stillborn fetuses. So, if it is greater than a few hours, some amount of basophilia is left behind. Whereas, if it is greater than 4 weeks, there is total loss of nuclear basophilia. So, here in this image, we can see there are some residual nuclei of the tubules and the glomeruli. So, these tubules and glomeruli have some nuclei, whereas here it is greater than 4 weeks. Here we can see hyperver image, the loss of tubular basophilia and glomerular nuclei is not at all seen. So this is a normal infant kidney. So here we have the first slide. Here we have the residual germinal layer present that may remain for up to 12 months of age. A high power view of the normal infant kidney. Here we can have the hyperchromatic nuclei, so many nuclei, hyperchromatic nuclei surrounding the glomeruli, the typical of glomeruli in the germinal layer. So these are my references. So any doubts or any suggestion, please comment in the comment box. Thank you.